However we decide to do the perineal end, we have a certain preference for the face down position for the reasons already stated. There is the question of the top end. Traditionally, this has been done open, and there's little argument against that, except that you do have an abdominal incision, and in the abdominoperineal operation, there is no need even for a specimen retrieval incision, so the whole of the top end can be done with, say, 4 laparoscopic ports. How far should the top end surgeon go laparoscopically? That's something for us to discuss as we go through a top end APE performed by our friend Eric Roulier from Bordeaux. So here we see Eric at work with the Advance, which is a monopolar diathermy instrument at the tip, and a ligature device, bipolar electricity, between the jaws. He is using the same principle that I like to use of traction, counter-traction, and monopolar diathermy to dissect in embryological areolar planes. We're now at the back and approaching that difficult area where the mesorectal midline fatty lymphovascular envelope of tissue that is the key of good cancer surgery, its intact removal, that is tapering into the external sphincter at the anal canal. Now we're looking further forward and identifying the seminal vesicles and trying to find the layer just behind them, which is Denonvillier's septum, a trapezoidal septum separating the onion-like posterior mesorectal compartment from the that you now see being developed there. Now the Denonvillier's fascia or septum is being divided to expose the mid-rectal, pre-rectal, mesorectal fat. So we back up to divide the mesentery above the specimen and the bowel to prepare for a colostomy and the approach to the perineal component of the operation. So Professor Roulier prefers to keep the patient on his back or her back to turn his attention to the perineal end in a conventional manner, first of all with an occlusion stitch and then with an oval incision around the anus without the extension up towards the coccyx, because he's not going to remove the coccyx. Anyway, we need to remind you that the patient is on her back or his back, and front is at the top of the anterior is at the top of the screen. The anterior dissection is being carefully conducted, and the same extra-levator plane developed around the sides and the front as with the face down. Professor Roulier would argue that he can do as good a dissection anteriorly with the patient in steep Trendelenburg, and we have even heard from some German surgeons. Professor Strasberg from Berlin puts the patient in such a deep Trendelenburg that you could put a cup of coffee on the perineum, but you also need to support the shoulders when you do that. But access anteriorly here by Professor Roulier seems really very satisfactory and difficult to criticize, and there's no doubt that it is simpler to keep the patient on his back if that is possible. So we're seeing a nice anterior dissection, which is anatomical and not blind. And one can see the vesicles there and the prostate. And perhaps it's possible to identify the neurovascular bundles, though not with quite the ease that we did in the face down position. So I think the controversy between face down and persisting with the traditional supine position will continue. The aim remains a specimen outside the levator with no waist, where the mesorectum goes down within the levator gutter. Basically, the bottom part of the TME dissection is not undertaken by the surgeon above, but instead an extra-levator muscle wrap is achieved by the surgeon below.